CPN and Families USA has joined together to do some really great research on health system transformation efforts and how we can really identify and put forth equity as a central tenet to these healthcare system transformation efforts. So I'm just going to provide a really brief update for all of you, and thank you for taking the time to learn a little bit about our research and give your feedback. I just want to say that this project is a long-term vision of both myself but also of CPN, and so it's really great to have the generous support of the California Healthcare Foundation and the partnership with Families USA to help move this forward. So one thing I want to address, and just ask folks if you don't mind just muting, because I know there'll be a lot of background information as people chime on. So one thing I just wanted to outline today is kind of why now and why CPN, and what are we planning to do with this project? What are we asking of you? And also just a note to say that I'm going to go through this really brief overview, and then we'll pause for a second and do a round of introductions just so that everyone is aware of who we are. But because we only have an hour, we kind of wanted to dive in. So why now? Well, we've known that California for a long time, communities of color had basically been locked out of the healthcare system. But with the Affordable Care Act, we really made tremendous strides in California in particular in reducing the number of uninsured in California. And if you see the picture, the graph, it's showing all of those dips are basically the dips in uninsurance rates. So we were able to cover a lot of people, and particularly for communities of color who really benefited the most. And as we look across the nation, we know that we're going to continue to see demographic shifts and changes over the next 30 years. And, as a note, CPN was really founded with a vision of the 4 ethnic leaders coming together to say, California is going to become a majority communities of color. How is the healthcare system taking this into consideration? So we feel like we're here together as state and national partners to sort of do the same for the nation. For a long time, we've talked about the triple aim and the need to improve health and increase, better care and have lower costs. But what's really not central to this is equity. And at the same time, we see over and over again reports showing that healthcare disparities are persistent. There's been no real effort to reduce those, or there's been no real progress, I should say, in reducing those. And in fact, they just continue to get worse in many cases. And so part of our work is to really say, how can we make this shift? So, CPN has had a long history of championing quality of care, and these are some examples of reports over the years, dating back to 2001, which was again funded by the California Healthcare Foundation, looking at patient satisfaction surveys and how they really didn't, consider the cultural competence of different communities. In 2010, we brought folks together to talk about building quality, equitable health systems. We've been doing great work around holding plans accountable for providing culturally and linguistically healthcare services in healthy families and other programs. And even just recently, we had a report on looking at data and analyzing data from the perspective of race, ethnicity, and language to better understand where the disparities are. So this has really been a central component of CPN's work, and I think now as we look at healthcare systems and the opportunities to transform them, we really feel like this is the time that we have in order to hold this decade-long of work into the conversation. And just kind of as a reminder about, what CPN is doing is that, as an organization, our role has been really to connect and convene networks and people, that we are bringing we're bringing community voices and stories into this leadership and advocacy process. A lot of our work is driven by community expertise, and that community members know and understand the solutions that they need, and how do we make sure that they're in that position of power to be able to bring those solutions to the forefront. And then we also advocate for those equity-centered solutions as we move our work forward. So just in terms of timeline, again, I gave you sort of the history, but then in the most recent years, we've really been working closely with our foundation and other partners to move this work forward. So in 2016, we talked to CHCF about, hey, we want to really shift the conversation in quality to look at disparities reduction. We were, having some great conversations, and then the November election happened, we got slightly derailed, and we had to really focus on the ACA defense work. But we know in California, we kept moving things forward. We solidified our ACA defense and kept moving the work forward. And in 2017, we had a great victory with Covered California, which identified a disparities reduction initiative. So within that, we had both self-reported data as well as year-over-year goals to look specifically at racial and ethnic disparities reduction initiatives in 5 different areas. So we started to make strides in 2017. And then in 2018, our partners at the national level, Families USA, brought together a national task force to look at equity and system transformation. At the same time, in California, we were advancing a bill to really move that work forward. And then at the beginning of the year, we really got an investment from the California Healthcare Foundation to do this more equity-centered work. And now here we are today. So the goal for the project, we kind of think about it in maybe 4 different phases. And so the first phase that you're here to learn about today is to really look at what are those equity opportunities and how are we assessing equity within the current initiative. So that's what you're going to hear about today. In the next phase, we want to really center community input. So we'll be having a set of community discussions as well as regional convenings over the fall to get more information and more assessment about where community members are, where our partners at the local and state level are around quality and disparities reduction. We're going to take this information back and really develop some recommendations. So we'll analyze the findings and discuss some, pathways forward. And then the final part is that we will be talking about a roadmap, developing some recommendations. And so as the work group members, we really want your feedback and ideas and thoughts around how those recommendations would best advance equity and health system transformation. So we're gonna, there's a saying, if you wanna go fast, go alone. If you wanna go far, go together. We're glad to have you be a part of the working group so that we can do this together. And I just wanna again thank the CPEN team as well as Families USA's team for helping make all of this work better and so we can go very far together. I'm going to hand it over to, let me stop for just a second so we can do that quick round of introductions. Why don't we kind of kick it off in the CPEN staff? So this is Sarah DeGia with CPEN.
Terry Sanders with CPEN.
And other CPEN folks, if you could chime in.
This is Jeffrey Coe with CPEN.
This is Saili Willis with CPEN.
And Families USA staff.
This is Raven Gomez with Families USA.
Elliot Fishman, Families USA.
Cristina Lectancio, Families USA. Can you hear us?
Yep.
You're good.
Yes.
Perfect. This is Sophia Tripoli with Families.
And then other working group folks on the call.
Oh, this is Margarita Pareda with Health Services. Sorry.
I heard Margarita. Do you want to introduce yourself and then Hung?
Okay, so yes, Margarita Pareda. Hi, Elliot. If it's the Elliot Fishman that I know.
Yeah.
Margarita Pareda. I'm with Los Angeles County.
Great. And was that
Tangerine Freedom Lake Foundation Health Services.
Great.
I'm sorry.
Go ahead.
This is Julio Porro. I'm Medical Director at Central California Alliance for Health, the Medi-Cal Managed Care Plan in Santa Cruz, Monterey, and Merced County.
Welcome. And did I hear Tangerine?
You did. Tangerine Brigham, Alameda.
Great, yay.
Yay.
So thank you all so much for joining us, and we promise we will have more FaceTime with you all as we move through this project. But since we only have you for an hour, we're gonna just power through so that we leave time for conversation. So we're gonna turn it over to Cindy with Families USA.
Hi, thank you so much for being here with us today. And I am going to try to speed through and actually not go through some of these slides. I know you all have copies of it. You can find more information on it, and you can also find more information about our Health Equity and System Transformation Center that we have at Families USA. So can we just go to the next slide? And the next one. Right. So the key thing that we want to talk about is Families USA has been now for several years focusing on trying to get more attention and action. No. Okay. Trying to get more attention and action around the intersection of health equity and system transformation. Because what we anticipated happening and we see now happening in the data is that system transformation has largely been happening without the input or the consideration of what impact changing how we pay for and deliver healthcare has on longstanding racial, ethnic, and geographic inequities. And so that is, if we continue on that path of expecting that system transformation kind of designed in a general way will trickle down to address inequities, we're going to be very, very disappointed. And in fact, the opposite is true. There is a lot of risk involved in the way, if we design payment systems in certain way, that things are actually going to get worse for communities that already are struggling with deep inequities. On the other hand, we can choose a different path where we are actually deeply engaged with people from communities that are most affected, leaders from those communities, engaged in this decision-making around how to change policy, payment policy, and how to change delivery. It can actually supercharge efforts towards achieving equity. But so far, that is not what has happened. Do we have a way to? Next slide. So to be very specific, the risk and opportunity of health system and health equity is, on the one hand, if we use data to find gaps that need to be filled, if we make sure that the money, when we are refocusing how money is spent, targets interventions that address those gaps, if we make sure that in doing that we're building links with health systems, between health systems and communities, so they can really address the full range of change that needs to happen for people to really improve, be able to take ownership and to actually have viable options for improving their health, and in that way also address social determinants, we can see how that's a pathway towards advancing health equity. But on the other hand, when we're thinking about payment not being tied at all to inequality metrics that reduce inequities, if in doing that we inadvertently create payment systems that incentivize avoiding complicated patients, many of which are from communities of color, if we, in trying to address that, create risk adjustment methodologies that simply hold providers harmless and thereby reduce accountability for improving equity, rather than actually figuring out how to truly create systems where you can risk adjust, but also invest in improving equity, improving outcomes for institutions that are having challenges in improving quality. And also by doing that, making sure that providers that are serving complex patients, such as safety net hospitals and community health centers, et cetera, are not financially, they may end up being financially undermined. And if we do that, inequities are just going to get a lot worse. So that is kind of the opportunity and risk that we are hoping, in partnership with CPEN and with all of you, to work together to figure out how to then design the systems and the policy changes and the policy solutions, and advocate for them and implement them in a way that we stay in the green of this picture and not in the red. Next. So we can go quickly through this. In December, we launched our Center on Health Equity Action for System Transformation. You can find out more about that on our website. Next. It includes these different kinds of programs. We provide technical assistance. We have a national network. We have been working with community health on a community health focused sustainability collaborative to get them paid through Medicaid. We're about to launch a transformation academies later in the year. And we also started all of this work basically with Health Equity Task Force for Delivery and Payment Transformation, which CPEN has been a part of. Next. Next. And so one of the first things that we did in the task force was we realized that there really was lacking a framework to think about how do we wrap our brains and our arms around the totality of what is payment and delivery reform and how it could serve communities of color and be a driver of equity as opposed to a way that might actually make things worse. And so we identified those 6 domains. The center of that is, yes, we need to have payment systems that sustain and reward high quality, equitable healthcare. But to get there are some pieces that are missing or that need to be improved, which include the evidence base and having the right equity-focused measurement. And then to implement it, we also need to make sure that we are investing in these safety net and small community providers so that they can be part of delivery system reform, that we have the right healthcare workforce, and that we are in this building robust community partnerships that are also well-resourced, which is a part that often gets forgotten. So that was basically our framework for thinking through policy change in the health equity transformation field. Next. And that's it. And I'm happy to answer any questions you have.
Oh, yeah. I'm going to pause this. We'll pause for a second. Anyone have questions for families? So I'm not going to go over these in detail, but just kind of as you think about your role here, we're asking you to really, you are the experts in the field. You're very supportive of equity, and we're asking for your thoughts and input as we talk through the research. And longer time through this working group is to be honest, provide your recommendations, and really bring your expertise and ready to learn. So I'm going to now pass it over I'm going to skip the timeline for now and hand it over to Carrie, who's going to talk a little bit about our research.
Great. So now that you've heard a little bit more about the project, I'm really excited to talk with you all about the research framework and findings. In the interest of time, we've abbreviated all of our findings for you today, but you should be able to access them in the Google Drive, which Sayuli forwarded to you earlier. The framework we created for this assessment was based very closely off of the Families USA Health Equity Framework. We ended up with 8 categories, including a separate category for social determinants of health. We then focused on payment and delivery system reform efforts in key areas, commercial insurance both outside of covered California and inside, public insurance in Medi-Cal and Medicare. We then went outside of and because California has bifurcated systems of care for oral and mental health, we looked at those services separately, and then we went outside of the traditional healthcare clinical model to assess our broader community health systems tied to the prevention and social determinants of health. So you're going to be seeing a lot of these yellow charts for each of the buckets that we're going to talk about. The circles indicate to what extent these systems are addressing, we feel these systems are addressing the issues that to the left that we're looking at, with a clear circle meaning that we feel that they're not being addressed at all, and a dark circle meaning they're being addressed entirely. All in all, between our 2 teams, CPEN and Families completed 37 assessments, which we bundled into several key findings. You should have access to those on the Google Drive as well. I'm going to talk about the California findings, including our thoughts for further state research. You'll have an opportunity to comment and react after each section, and then once the California presentation is over, I'll turn it over to our national partners from Families to talk about some promising national models that could be applicable to California and where we may want to do additional research as well. So starting with the first bucket, we started with commercial insurance because, in many ways, commercial insurers in California have been the pioneers and innovators in delivery system and payment reform, for example, through commercial ACOs and bundled payments. This is actually one of the reasons why we wanted to start with this system. Most key stakeholders we see, including health plans, employers, medical groups, hospital health systems, are engaged. Many activities have been incremental or foundational, such as pay for performance, developing core sets of quality improvement measures, supporting health information technology. However, while there's much to learn in terms of these innovative models, almost none of the activities explicitly addresses equity. There's no demographic data collected or analyzed, and no requirements for disparities reduction. Some FQHCs and public hospitals do participate in QI activities, but the safety net is not a central focus of a lot of these efforts. We then looked at Covered California because, on the other hand, it really sees itself serving playing a much more active role and serving a lower income population. 90% of enrollees receive subsidies, and they have set very ambitious goals for quality improvement and delivery system reform. Examples including such as the 60-day PCP assignment, encouragement of ACOs, and hospital pay for performance. Covered California also approved the first in the nation requirement that plans show year-over-year progress in eliminating disparities in key target areas: diabetes, asthma, hypertension, and mental health. While this is all very exciting, progress is limited by a lack of public reporting and accountability. Plan performance is also very uneven when you're looking at a lot of apples to oranges in terms of plan size, plan type. There's PPO versus HMO, and the population served, Medi-Cal serving plans versus commercial-only plans. Covered California is interested in being a trailblazer in equity, mental health, and the social determinants of health, and they want our help in figuring out how best to do that. So as we think about suggested areas for further research, the biggest questions we really have are: what strategies are most promising in the commercial world? Which practices could be applied to other populations? Can we integrate equity requirements into some of these existing commercial systems? And can we leverage these systems across payers to maximize efforts? And in Covered California, we're really working on strengthening the public reporting requirements. But what does good public reporting on health equity look like? And speaking of leveraging other innovative models, are there models in Medicare like CPC Plus, which families will discuss, that we might want to leverage in Covered California? And finally, we hear a lot about California, but are there other states doing interesting things around with their marketplaces around equity and disparities? So I'm going to stop here just for a moment and see if there are any questions or thoughts on commercial before we move to Medi-Cal and Medicare. Okay.
I have no questions.
All right.
None.
Great. And if things occur to you after, please feel free to email. So just jumping into Medicare and Medi-Cal. So now we looked at both separately. Similar to the world of commercial insurance, Medicare has really been a driver of payment reform activities, and there's been a lot of these types of activities in California. However, when you look at disparities reduction requirements, there's really no specific requirements. There's some optional activities. There are some new demographic data reporting requirements, but it's still kind of early to see how those are playing out. There's some participation of ACOs, there's some participation of ACOs, but no real specific activities around social determinants of health and workforce diversity. With managed care, we looked at both managed care system of care and several delivery system reforms included in the 1115 waiver, such as GPP and Prime, but also the community clinic alternative payment model proposal, which unfortunately did not advance. You'll notice that whole person care is not included in the table, but only because we discussed that in the mental health section. California took advantage of the last 1115 waiver to infuse a lot of payment and delivery system reform activities to help revamp the safety net. And while some of these initiatives address disparities through data collection and reporting, there are a few actual requirements for disparities reduction. Data integrity continues to plague disparities efforts across systems. And we find the level of community engagement, at least with regards to managed care plans, could use some improvement. There are surveys, for example, that are done every 5 years, group needs assessment surveys, but it's not really clear how those are being acted on and how they're tied to quality improvement strategies. Ultimately, we found no required activities in the 1115 waiver that specifically address workforce diversity, at least that we were aware of. And so as we think about moving forward and future research, again, we ask the same questions in Medicare as we did in commercial. What strategies are most promising? Which practices could be applied to other populations? Can we integrate equity requirements into some of the existing Medicare systems? Can we leverage these activities across payers to maximize efforts? And we are curious to see how the quality payment program in Medicare is being implemented. So those are some areas that we're interested in looking more closely at. In Medi-Cal, we wonder, how might consumer engagement activities be improved to foster better community health? And speaking of leveraging other models, are there value-based payment efforts in Medicare that could be leveraged in California to achieve maximum results? How can we better tie payment to health equity and managed care, safety net payment, and delivery reforms? And how can we ensure the managed care systems are coordinating with other systems of care, which we'll talk about in oral and mental health? And finally, what are some specific strategies to ensure the sustainability and accountability of our safety net systems to ensure they're meeting the needs of our diverse communities? So I'll stop there and see if there are any questions on that. And again, this is the abbreviated version, so apologies for rushing through this. Okay. So now just briefly to turn to mental and oral health. Our assessment of mental health in California yielded a few surprises and some more predictable problems. Because of our mental health carve-out, with specialty mental health provided at the county level and mild to moderate at the plan level, quality measures lack uniformity across delivery systems. And also surprisingly, utilization of the mild to moderate mental health benefit is far lower than what we see at the local county level, despite the fact that many more Medi-Cal members should be eligible for and in need of mental health services provided by health plans. Delivery system reform efforts like whole person care were largely focused on coordination of care amongst the different plans and providers, but equity efforts must also focus on improving coordination of care between mental health and physical health care. Mental health disparities persist, but mental health equity goals are not explicitly required across all systems to incorporate disparity-sensitive metrics. And although all systems of care show varying degrees of delivery system reform, efforts seem to lack a focus on integration, coordination, and sustainability. And as we looked at oral health, we actually found some similar patterns. Utilization rates for oral health care services are some of the lowest in the nation, although that may be changing in California. California is piloting several promising payment and delivery system reforms, such as the Dental Transformation Initiative for kids and the virtual dental home that could help to eliminate disparities in access to care. But measurement systems in general are primarily focused on kids and on processes versus outcomes, and disparities reduction, while prioritized, is not yet required. So in terms of future research for mental health, we will be asking ourselves, what is the next step for California's waiver reforms, such as whole person care, the drug organized delivery system, and MHSA innovation? What opportunities exist to standardize metrics, improve care coordination, and incorporate more disparity-sensitive metrics across the various systems of mental health care? And what opportunities exist more broadly within DHCS's Medi-Cal managed care quality strategy to ensure providers, primary care providers, for example, are better integrating mental health into their own systems of care? And then with regards to oral health, we have even broader questions. How should dental quality be measured? The lack of national standards here makes this a key question for us. can California play a role? What's next in terms of some of the 1115 waiver initiatives with, for example, the Dental Transformation Initiative and virtual dental? We're looking at that closely. I imagine, Hong, you all are looking at that as well. How are the various systems addressing the social determinants of health, and should they be focusing broader to policies around sugar-sweetened beverages, et cetera? This will be part of our call on social determinants of health, which we're holding on June 26th, where we'll go into a lot more detail about those questions. But just a flag for you right now. And now I'll just pause and see if there are any questions about mental and oral health. And I think and before we hand it over, I think just for all of these buckets that we've gone over with you, and you can, again, reply by email or other formats are fine. Are we asking the right questions? Are there things that we're missing? Are there promising models that you would like us to delve deeper into? Those are our overarching questions as we move through this and as we work together with you all. So if there's nothing right now, I will turn it over to our national partners at families.
Awesome. Thank you very much, Carrie. I'm going to just talk for a minute about Medicare and then hand it over to Elliot Fishman to talk a little bit more about our research in the Medicaid space. And then he will turn it back to me if time permits to do a very quick overview on oral health. I think you'll sort of notice themes coming up. What we're going to sort of present on is a snapshot of sort of the sense of what's happening across the country and in states in terms of delivery system and payment reform models, innovative approaches, and sort of what's happening as it relates to health equity. And the common theme you're going to see throughout all the models we sort of tick through is there's some really big, as not to anyone's surprise on the call, but really big holes in terms of how these models are thinking about health equity, or in some cases not thinking about it at all. So if you go to the next slide, please, and the next slide after that. Thank you. So in Medicare, we looked specifically at the Comprehensive Primary Care Plus initiative as one of the models that we sort of looked at, and are highlighting it here because it's we think sort of a promising model, an interesting model in terms of how CMS is thinking about primary care, both in the current state and then as we're seeing primary care continue to be of interest moving forward, and new RFIs and requests for information that are coming out of the Center for Medicare and Medicaid Innovation. CPC Plus in particular, just to say a couple things, the next 3 or 4 slides sort of give a lot more detail about the way that the delivery system is sort of organized in this model, as well as the payment models that are being tested. But I think if you move to the next slide, knowing that California is currently not participating in CPC Plus, I think what's interesting about CPC Plus is sort of some of the elements that could be applied as we're thinking about opportunities in new models or existing models, and things that could be baked into sort of a California approach to health equity and systems transformation. This slide and the next slide sort of just talk about the 5 key buckets of care delivery requirements that practices are required to have as part of the CPC Plus model. Access to patient care 24/7. Just on that one's perfect. Levels of risk stratification, and as you'll see, there's sort of 2 tracks in CPC Plus. A track for track 1 is for practices that are somewhat farther along in terms of some of their basic infrastructure and care delivery skill sets, but then track 2 is really sort of the next level above and beyond. So it tries to sort of encapsulate primary practices where they are and make an opportunity for practices at varying levels to come into the model. And if you could go to the payment slide, perfect, thank you. And then this slide really just highlights there are sort of 3 payment approaches or innovations as part of CPC Plus that are interesting. One is a care management fee that's essentially a non-visit based case management fee that's paid per beneficiary per month. This is a Medicare fee-for-service fee. It's paid on a quarterly basis. It's risk-adjusted, and it's a way to sort of incentivize, a payment for care management. In track 1 and track 2, you see there are different amounts depending on the track and sort of the level of complexity of the patient population that's been attributed to that primary care practice. The other second payment model is a performance-based incentive payment. This is a prospective payment that's made with a retrospective reconciliation based on how well the practices are performing on a set of quality measures and patient experience measures and clinical quality measures that are sort of overall driving the total cost of care. So this is made upfront, and then it's retrospectively sort of modified at the end of a plan year based on how well that practice did. And you can see again, track 1 and track 2, $250 per beneficiary opportunity in track 1, and then in track 2 up to $4. And then the last payment structure or payment sort of innovation being tested in this is it's payment under the Medicare physician fee schedule. So in this model, track 1 continues to bill and receive payments for Medicare as usual, fee for service Medicare payments as usual. And then in track 2, providers bill Medicare as usual, but the Medicare payment is actually reduced to account for care shifting of a portion of its payments from fee-for-service into sort of a comprehensive primary care payment that's paid on a quarterly basis, and it's in a lump sum and without claim. So kind of a testing and approach moving away in track 2, away from fee-for-service and more in sort of a population level type of payment. So I think those are just 3 sort of innovations happening in CPC Plus on the payment side that are just interesting to think about in terms of what that might look like in a California context, and to sort of learn and for us to be tracking, what are the outcomes, what are we starting to see in terms of the impact of CPC Plus, if anything is popping out at us. If we go to the next slide. I think key takeaways, again, not super surprising. Equity is not an explicit focus in the CPC Plus model. At least in terms of the design of the delivery, structure and the payment structure. And then, of course, data issues across Medicare in terms of reporting on, stratification of data and quality measures continues to be an issue. And if you go to the next slide. So we have just some suggestions for further research that we sort of were thinking about in our next iteration as we go back and think about Medicare models, other models we might want to think about, particularly around bundled payments, episodes of care, and how they may or may not be interacting with health equity, and what we can learn from those and apply to the work here. And then I think with that, I will pause for just a second and see if there are any questions about CPC Plus or Medicare sort of in general in terms of our assessments. And then I'll hand it over to Elliot to talk in more detail about our Medicaid research. Any questions from folks? All right, Elliot, I turn it to you.
Okay, why don't we go ahead, one more slide after this one. Okay, so we have information in this slide deck in this section on 5 states, and we're concerned that going through all 5 on this call would really take up all the rest of the time that we have, and also it would just kind of weigh down the whole conversation. So what I'm going to try to do is just to pull some of the key takeaways more broadly from those 5 states, and then quickly summarize some of the distinctions. So we should be thinking about the way that these states are organizing their providers and changing Medicaid payment for their providers as both an intervention in terms of care delivery that can potentially serve health equity, but also as a platform for measuring performance, and specifically for either stratifying performance measures by race and ethnicity, or measuring types of performance that we anticipate will bear directly on improved health outcomes in communities of color. Right, so there's both aspects here. It gives you a mechanism particularly to potentially integrate community-based organizations delivering social and human services with Medicaid paid healthcare delivery. But it also gives you an address at the regional level that is potentially accountable for performance in terms of advancing towards health equity and narrowing disparities in outcomes. So all of the states that we have described here have some sort of a regional structure that brings providers in that is clearly tied to the Medicaid program, either in terms of being insurance entities or serving an administrative oversight role that pulls in both acute medical care, behavioral health, and to varying extents, LTSS, and housing and human services CBOs, right? They're creating some sort of a new regional structure, which then has a table where all those different parts of service delivery can collaborate together, both in administering care management and in oversight of their shared community responsibilities. So here I'm going to actually ask to skip through the next few slides where we go through the individual states. I, of course, encourage you to read them. They do reflect the research that we pulled together for this project. And go to the takeaways, I think comes right after North Carolina, so you're almost there. Key takeaways, right? So first, just by way of overall summary. So Massachusetts, Minnesota, Oregon, and North Carolina, 4 out of these 5 are in some way contracting with these regional provider entities for as insurance entities for the delivery of healthcare. In Massachusetts and Minnesota, that takes the form of accountable care organizations. In Oregon, as I think many of you have heard, since that program is high profile and has been around now for a few years, that takes the form of managed care organizations that are regional and provider-based, called CCOs. North Carolina is new, and it is going along with a broader transition from fee-for-service to managed care. What I would describe the way their system looks on paper is it's a lot, to me, reminiscent of whole person care in the Prime waiver in California, but broader in terms of scope and statewide. So that's one theme to take into account across the board. Another is that all of these states are looking at stratifying measures, right? There has been some significant progress in terms of awareness at the state level, at least in these states, of the need to stratify measures by race and ethnicity, but only a couple are just starting to move forward on paying for performance in terms of performance stratified by ethnicity or otherwise measures that are closely tied to equity. So that's an area that I think we are likely to be discussing quite a bit in a Medi-Cal context, but it's an area in which we're going to be more tracking how states are planning towards that goal than pointing to mature state models in terms of paying for equity performance. Okay, and then Sophia, I think I am handing the mic back to you.
So I think the only thing I'll say on oral health, because I want to turn it back over to CPEN, make sure we have time to get through the rest of the agenda, is if you could just go to the next slide. One more. we looked at it, and then one more slide, please. So we did look, do some sort of a landscape overview of oral health sort of innovator projects. We looked particularly at Dental Quality Alliance and some of the innovations that are happening in these three states here, Michigan, Virginia, and Massachusetts. And then if you flip to the next slide, I think the key takeaway here in oral health in terms of national models and what's going on is oral health continues to sort of, in terms of the innovation space around payment and delivery system reform, continues to sort of occur in a silo, separate and apart from the overall healthcare delivery system. And that's even more so when we think about health equity. So I think in terms of further research, I think, we want to, if you could flip to the next slide, I think we suggest sort of thinking a little bit more and doing some more investigation around some of the barriers that are, in terms of evidence-based interventions for payment delivery reform initiatives for oral health specifically, and try to unpack that a little bit. What are some of the biggest barriers that are being faced there? And I think with that, I'll turn it back over to the CPEN team.
This is Tangerine. I do have one question.
Sure.
Okay, so I'm looking at where you say lack of focus on adult oral health. I mean, I think we all recognize the reason for the lack of focus is really the money, right?
Right.
Yeah. Health for adults who have, I like to use the clinical term, banged up mouths sometimes. It's really expensive than doing sealants for kids. So how much of your work is really how to address the cost issue, particularly given that dentistry in general really functions more like sort of independent small businesses, which is a very different delivery model than a hospital or a community.
Absolutely. It's such an important point.
Yeah, and what I think we will add to the list of questions, so as we continue to do our research and kind of delve in, is thinking about that delivery system and how it has an opportunity to be integrated, or what are some of the challenges to be integrated into the overall system. I will say in California, I think the virtual dental homes is trying to kind of get in some ways to that level, or a lot of talk around changing the scope of practice or utilizing RDHAPs or dental therapy or other oral health professionals to really help with some aspect of it. But I definitely hear the cost and the kind of operation of the delivery system. So let's use this as an opportunity. I think two questions we wanted to throw your way is, one, what information or findings are sort of resonating with you and that you're like, this is great, we want to hear more. And secondarily, what do you feel like is missing, or where do you have these additional questions that we might delve into in the second phase of the research? So what's kind of working and resonating, and then where are the gaps that we may want to think about moving forward?
This is Margarita from Emory County. I'd say that your whole presentation resonates with, what's happening in Los Angeles. I think the questions or the comments on oral health are particularly relevant. We've recently have started to tackle system-wide what we're going to do with the limited resources that we have within the county, and how we can actually risk stratify individuals so that we maximize it. I feel like children seem to have better access to dental care, and again, it does go back to the adults where it's very difficult. And how do you risk stratify and somehow build a crosswalk between the highest risk individuals with maybe chronic illness, right, and being able to maximize when you have limited resources in a place like this. One area where we feel like we've already hit a barrier, and I would say that we probably hit this barrier anytime that we're trying to expand outside of the traditional providers, so expanding scope of, the dental hygienist, our pharmacist or whatnot, when it's outside of the MD, DDS realm. we hit up against, labor union questions and issues. So more of a comment I would say that in terms of stakeholders, that might be important for you to bring into this discussion, and particularly in the public sector in California would be those representatives. Because I think that when we try to expand the ability to, even when we bring up these discussions, they're so out of the realm, they're not part of these discussions where they see that there's a greater good that's happening here.
That's a great point. Thank you.
This is Julio Porro, and really enjoyed the presentation. One of the pieces that I think really merits focusing on, at least from the Medi-Cal side, California, again, Medi-Cal side and managed care piece, is the very limited amount of consumer engagement that there is. From my perspective, G&A surveys are helpful, but I really don't see them, one, providing the detail, or two, ultimately dramatically changing the approach of the health plans and addressing the community's needs. I really do think that, for most of the Medi-Cal managed care plans, we take care of a very, very diverse community, and we need to have those consumers be part of the table, be around the table in the decision making. And unfortunately, for us, and I know that we're probably not the only ones who do that. We have a member advisory group, but we have no members who are part of the member advisory group. It's usually headed by organizations that represent the interests of members. But again, we don't have members themselves. So I think there's probably small movements, small improvements that are kind of happening. Certainly, whole child model has changed the way that we involve our consumers. But I think this is really a place that needs to happen, that needs a focus across the Medi-Cal plans.
That's great. Thank you so much for that input.
Yeah, very helpful. Thank you. Are there other thoughts too? Just, even on the entire, breadth of the presentation. I know, again, we had to rush through things really quickly, but we are interested in your feedback and your observations.
You may have said this, and I missed it. This is Tangerina Brigham again from Alameda Health System. But, we've got anywhere from, 10 to 20% of the state's Medi-Cal population in Medi-Cal fee-for-service. And just recently, I had to try to deal with a patient issue, and it was amazing how difficult it was, from trying to get a TAR approved, a treatment authorization request. And so I know you mentioned in the presentation, this is the longer one, the Medi-Cal fee-for-service population, but how are you thinking about that population, given the fact there's not a ready group or entity other than the state that you can work with to advocate, around health equity issues for that population?
Yeah, that is an excellent question, and you're right. I did include that in the longer slides on the background piece. It's particularly challenging because you're right. Like it's kind of a patchwork of folks who are undocumented immigrants who are getting particular certain services, and then folks who are sort of temporarily in fee-for-service before they move into managed care. But so, I think I guess what I would say is, let's put that in the queue of okay, what are we going to do about this particular population, but also, would welcome any thoughts or questions or observations that you have about the way these systems are interacting that we might want to try to address in terms of our research.
So just to quickly summarize, I definitely heard the cost of oral health in adults, that's both a challenge and sort of at times some of the reason why there's sort of decisions made across the whole, kind of spectrum of health. And so like looking at the cost of oral health in adults, making sure that we're thinking about labor unions as potential stakeholders and what that role is. Consumer engagement, both as like a need and also a place where we might have some potential opportunities there. And then fee-for-service, the system, there's the managed care system, but the fee-for-service system, and kind of how do we drill down a little bit deeper to understand the equity implications within those. Those are kind of I know Carrie took longer notes, but those are sort of the big questions that I heard coming out. Just in our last minute, just kind of any final closing thoughts from the work group members? Right. Well, thank you so much for your time, and we look forward to having you on the social determinants of health call, which will be on the 26th, and it'll be, an opportunity for you to kind of see in more depth kind of how we went into the presentations. I do encourage you to look at the background data as well, and we may follow up with a few of you on some of the points that were raised today, just to make sure that we understand or can gather a little bit more information as we go forward. Families, folks, any last minute comments from you all?
No, we definitely look forward to hearing more from everyone.
Yeah.
And Margarita, this is Elliot. It was great to hear your voice as well.
Oh, great. Thank you. Thanks, everyone.
Thanks, everyone.
Thank you.
We'll be in touch.
Thank you so much.
Thank you all.
Thanks, guys.
Okay.